early Tuesday show, which is 4 o'clock instead of 4:30 my time. Turned out that's a little bit better for me. But today, hi Nicola, everything's going to be happening on Facebook and YouTube. So jump over to CNY Fertility's Facebook page. So we're going to be doing a presentation on our second part of our presentation on endometriosis. Hey, everybody. Hi, Ashley. Thank you for joining us on the Facebook side. All you Instagrammers, which I adore, all 43 of you, jump over to Facebook Live. Now there's 41, 40. Everybody jump over. 39. We're all jumping over to the Instagrams, from Instagram to Facebook Live and YouTube channel, because we're going to be talking about endometriosis today. Hello, Rachel on the Facebook side, Yacinda, Melissa. Hello there. Nice to see you all. Edna, Dean, everybody who's on Instagram, jump over the Facebook side. This week is hey, Caitlin, Sage, Kirsting, Puffer, my favorite gal. Hello, Dr. Hello there. Tasha, Bruce, good to see you. Saturday Johnson, jump over to Facebook Live, everybody. We're going to be doing a talk on endometriosis. Today. This is the second part. Every other week I do a lecture, so every other week I do questions and answers. Last week was question and answers. Hello, kissy kissy, love everybody. So everybody jump over to Facebook Live. Yep, there you're jumping on. I can see. Jump over. You guys are here who are on Facebook Live. Hello, we're going to be talking about endometriosis. Welcome, Jabal, Alexandrum, everybody jump over to Facebook Live who's on Instagram, because we're going to be talking about endometriosis today. K Jefferson 01, jump over to Facebook Live. Hello, Rachel. Does laparoscopic surgery help to increase the chance of conceiving? Yes, it does, especially if you diagnose endometriosis. So everybody on Instagram, please jump over to Facebook Live. We're going to be doing a talk on endometriosis. Michaela, hello, nice to see you. Alexis, jump over to Facebook Live, fantastic. It's Bren Life, jump over to Facebook Live. Kay Jefferson, jump over to Facebook Live. We're going to be doing a more comprehensive look at endometriosis. Ingrid, does Colorado do laparoscopic surgery? Of course, we have Dr. Walensky, who's a consummate gynecologic surgeon. We have Dr. Fink, another wonderful surgeon. Keeping up with the Andersons, jump over to Facebook Live. Erin Keeley, jump over to Facebook Live, because we're going to be doing our talk on endometriosis. And then later on, we'll answer some questions. Marich US, III, IVF Babel, jump over to Facebook Live, because that's where all the action is today. Carolee Gable, jump over to Facebook Live. We're going to be doing a talk on endometriosis, its identification, its treatment options. It's a three-part story, endometriosis, and this one is going to be a brief review and overview. So it's kind of 1.5 on our story. And then, like I said, every other week, we do question and answer. This week, we're going to be talking about Facebook Live. Having surgery at the end of September after 8 years of secondary infertility. Great, Rachel. It's important to find out if there's endometriosis. Cryptic or hidden endometriosis can really affect you guys. So everybody on Instagram, I'm going to jump over to Facebook Live. So you guys jump over to Facebook Live and we'll get the presentation started. Okay, I'm going to start the presentation, and then in about 20 minutes, we'll talk about questions and answers. But everybody who's on Instagram, jump over to Facebook Live. So we're going to be talking about endometriosis, its identification, treatment, and the options. We're going to talk about what it is first. So endometriosis is tissue from the endometrium, appears in parts of the body lying outside the uterus. The ovaries, fallopian tubes, uterine ligaments, so I can point those out. So there's the ovaries with endometriosis, the uterus with endometriosis, the ligaments with endometriosis, the vagina down here with endometriosis, the colon with endometriosis. You can endometriosis on the liver. So you can see on the sigmoid. So endometriosis can be jump over. So everybody who's on Instagram, please jump over to Facebook Live, okay? Endometrial tissue still responds to the hormonal cycle, and that's the problem, is that you can have actual menstruation inside the body, and it builds up and sheds every month in the uterus, but where can it shed in the inside the body? Of course, to other tissue. So the tissue has no way of escaping. So what do the patients tell us who have endometriosis or who don't know they have endometriosis? Well, the first thing they'll say is, I'm not able to get pregnant. Something they may say is, I feel like there's something in my belly, some mass. That's called a pelvic mass. They say it hurts when we have intercourse, especially in certain positions. That's dyspareunia. My periods cause me really a lot of pain. I mean, more than most folks. Well, that's dysmenorrhea. And I seem to spot or have vaginal bleeding. That's dysfunctional uterine bleeding. I'm in pain all the time, pelvic pain, chronic. And these are all signs and symptoms that you may have endometriosis. So it's critical to understand it does affect your infertility, but it also affects your life. So all those folks on Instagram, jump over to Facebook Live. We're doing a lecture on endometriosis. So jump over to Facebook Live, guys. So how do you know if your patients have endometriosis? Well, the first thing they talk about is pain. That's your first clue. But then they also say that their pain seems to be cyclic or cyclic during a certain part of the cycle. So that's your second clue. And then I've been having this for years and years and years. So there's your third clue. So guys, gals, be aware of these symptoms and tell your doctor, have him document it, because sometimes that's the only way we can get the insurance companies to pay for your diagnostic laparoscopy, okay? So some of the symptoms is dysmenorrhea, painful menstruation, dyspareunia, painful intercourse, premenstrual spotting, chronic pelvic pain, bladder or bowel problems. So here you can see a nice image of a uterus that seems to be normal. This side is all normal, but on this side you see there's endometriosis on the ovaries. This is a chocolate cyst, which is an endometrioma inside the ovary. Here you see a beautiful fallopian tube that's nice and flowing here, whereas on this side it's all kinked up and scarred with adhesions. And here you see a lot of what we call powder burn endometriosis, as if somebody put a cigarette out in your pelvis. And if you have intercourse and the penis is right here pushing, believe me, this is painful. So those are some of the symptoms, and here are some of the signs. Friable perineal implants. So in other words, you can actually find implants on the outside of the vagina that are friable. They break and bleed. A laterally deviated cervix. If your cervix is pulled, let's say, to the left here, it's likely that there's endometriosis doing the pulling. Fixed or retroverted uterus. In other words, if all your life your uterus was tilted towards the forward and now it's tilted towards the back, basically what you find is that they have a lot of scarring in the posterior cul-de-sac. If you do a pelvic exam on these patients, when you do the pelvic exam, this should be nice and smooth, but over here is nodular. So again, your obstetrician, your reproductive endocrinologist, your nurse practitioner, they can diagnose symptoms and signs of these. Adnexal masses. If we were to do a pelvic exam, you feel a big, huge ovary over here, but it's actually an endometrioma. And of course, excessive pain on palpation. Endometriosis is one of the most frequently diagnosed gynecologic disease in about 10% of women. So if you have 10 friends, one of those 10 probably has endometriosis. And if it's an infertile person, 25% or 1 in 4 women have endometriosis. A lot of times there's controversy about how it all started. Why do I get it? Why does it run in families? Of course, that's controversial. And in adolescents who, from very young, talk about painful intercourse or chronic pelvic pain, is about a 50 to 60% chance that they have endometriosis. Okay. So this is Dr. Dan Martin. He believes that 100% of women will have endometriosis at some time in their lives. The purpose in my saying this is so that if you're not getting pregnant with IVF and it doesn't make sense, make sure we do a diagnostic laparoscopy. If you're not getting pregnant, but you got pregnant easily when you were younger, do a diagnostic laparoscopy, because it may well be that over time you've you've gotten the disease of endometriosis. Is there a change in its prevalence? Well, the answer yes. Increasingly because women are exposed to many more times than the past in the sloughing of the endometrium. They may seed itself and trigger painful endometriosis. In other words, more time menstruating. And this is also a hypothesis. The reason there's an increased prevalence is it's hypothesized without being pregnant, pregnancy tends to burn off the endometriosis. So you're more likely to be exposed to estrogen without progesterone, so therefore you see more of this in couples. And then some people say, no, there's not an increase in prevalence. It's really because of increased public awareness, increased physician suspicion, and we're better identifying tip of the iceberg lesions, which I'll talk to you about. So yes, as there are more, it's hard to say, but the bottom line is it does exist. How do you diagnose it? Well, first and foremost, the diagnosis is surgical. A surgical specimen is the key way to diagnose. We can infer you have endometriosis from all those signs and symptoms, and we can actually treat you symptomatically. And then, of course, operative laparoscopy is the most used diagnostic modality. That's what I was talking. So what does it look like? It's basically, I say it's you place a telescope through the belly button, you look in the pelvis and you see a chocolate cyst, you see fibroid, you see adhesions. This is endometriosis on the ovary. Very, it may not be easy to see, but it is. And then that's the best way for us to diagnose endometriosis. And what does a typical lesion look like? Well, it's got these little purple spots, red, hemorrhagic. They bleed real easily. But guess what? This is endometriosis. And you're saying, well, wait a second, that looks normal. Well, if you look really closely, you may not be able to on the slide now, but later on you will. You'll see these little blebs on the peritoneal tissue, and those are actually clear endometriosis. Which brings me to the fact that you can never really get rid of all the endometriosis surgically. You can't, because you can't see it all. So if we walk into a couple and we ask the question, will this woman have my pre-op diagnosis endometriosis? And about 10 to 15% of the time we'll find it. The incidence for people who are getting tubal ligation, right? These are people who've been pregnant, is about 2 to 5%. So that's another reason why you're in there. People with an infertility diagnosis will have anywhere between 25 and 40% of them will have endometriosis. And then just people walking in the door with no symptomatology who happen to have surgery, let's say for an accident, about 5 to 10% will have it. So you can see the incidence changes, but in our population of infertility couples, man, it's 1 in 3 and maybe 4 in 10 will have endometriosis. Are there racial bias or etiologic factors? Well, yeah, of course, you're not going to know if you have endometriosis if you can't do surgery. So there's the availability of healthcare. Contraception, of course, is gonna bias your diagnosis. Cultural patterns, if you're a late childbearing age or young childbearing age, that'll determine the etiology of whether or not you have it. And then if it's certain attitudes, and there's one caveat: Japanese women tend to be twice as likely as Caucasian women to have endometriosis. So what is the theory? Well, the theory behind endometriosis is regurgitation out the fallopian tube of exfoliative endometrium. What does that mean? Instead of menstruating out the vagina, you menstruate out the fallopian tube. That menstrual tissue has endometrial cells. They seed the peritoneal cavity, and it grows, much like a weed. Coelomic metaplasia simply means some cells just change from one type to another. And then other ones say it's because embryologically you had cell rests of Mullerian origin that may have been around since you were an embryo, and these may be causative. Doesn't really matter what the cause is, because from an infertility standpoint, that's what matters. All those folks on Instagram, jump over to Facebook Live. We're talking about endometriosis, and then we'll get back to talking about questions and answers here in about 20 minutes. So what are other factors if you're looking at endometriosis? Well, there's a 7% chance if you have a first-degree relative, mother, sister, who has it, you have it. And if your cousin has it, you have a 2% chance of it being genetically caused. It's a maternal inheritance, so it's not your father's mother who you have to be concerned about. It's your mother and your mother's family that are more likely to cause that to go down the line. So what I ask patients, is there anybody in your mom's family or your family that has endometriosis? We're looking at sisters and moms. If a person has an abnormal uterine configuration, they have uterine didelphys or bicornuate uterus or only one horn, these folks have a huge increase in endometriosis because the blood can't get out. Or if they have a short menstrual length but prolonged menstrual flow, then you're twice as likely to have endometriosis. The reason I want you to know these things is we want to do, when it's appropriate, diagnostic laparoscopies to find out if you have it, because it doesn't impact fertility. You don't tell people that's the reason you have endometriosis because you didn't have children or that you use tampons, birth control pills, pregnancy cures endometriosis. They're not. They're not the causes, and so that puts blame, and we don't want to put blame. So what does it look like? Well, it could be a hemorrhagic cyst, a chocolate cyst. It could be an adenomyoma, adhesions. It could have pockets in the endometrium, purple raspberries, red raspberries, blueberries, blebs, and it could also look a lot like cancer. So what does it look like? As I've shown you, you have these little implants all over the pelvic cavity, or you could have just one. And by the way, the number of implants is not proportionate to the actual pain. So you might have one implant and you may be in a huge amount of pain, or you may have your whole body with implants and you may not feel pain at all. So here's a little better picture showing you the damage from endometriosis on the uterus and on the ovary, on the fallopian tubes, adhesions, the locations. Usually it's in the pelvic cavity, but it can be in the brain, it can be in the lungs, it can be in other parts of the body, in the skin of colon. So it's quite a differentiated disease. And here's those cigarette burn lesions. It looks like somebody put a cigarette out inside in the peritoneal cavity. And these are very indicative of endometriosis. And you excise this, you get rid of it. You cut it out once you're in there. And then here's that tip of the iceberg. So this one looks pretty benign. It's a little bump. Everything's smooth. Everything's fine. But then if you break that bump and you look at it, it turns out that that actual little bleb is below it is this huge pocket of necrotic tissue and old blood. So you could be deceived with that. There's one little bleb and you say, oh gosh, how could that be a problem? Well, it absolutely can be a problem. There are various ways we communicate the severity of endometriosis. In other words, some people go stage 1, 2, 3, and 4. Some people say mild, moderate, severe, extensive. Typically, mild is managed with surgery, and all of these are managed surgically. But typically, mild doesn't have as much of an influence on fertility as moderate does. But once you get to the severe and extensive, not only do you have a biochemical reason, the inflammation caused by endometriosis as a reason for infertility, but now you have mechanical things like scar tissue, adhesions, you have endometriomas, you have disfiguration. So mild, we would call it superficial, teeny little blebs, moderate implants with puckering and fibrosis, ovaries moderately adherent, multiple implants on the bladder and ligaments. But once you get to severe, you have the endometrial cyst or endometrioma, you get the tubes involved, dense adhesions, and in some cases you completely obliterate the cul-de-sac behind the uterus, and that's where most couples who complain of dyspareunia, painful intercourse, are most affected, okay? They're most affected. All right, so I'm just showing you different ones here, and of course that's a normal cavity. Extrapelvic, you can have cyclic lung symptoms where you every month with your period you spit up blood. You could have cyclic headaches, which every month at a very specific time, you get these really sharp headaches that could be brain endometriosis. You could have it so that cyclically every month with your period, you get bleeding from the rectum. And again, as you can see, they've even found endometriosis on the hand, on the shin, on the forearm, in the lungs, in the brain. So it can be pretty ubiquitous. So why do I use the term at endometriosis is like cancer? Well, in cancer, you have peritoneal spread of the cancer, while in endometriosis, it spreads peritoneally. In cancer, you can distort the shape of the ovary. In endometriosis, you can distort the shape of the ovary. In cancer, you have unbridled growth, it's just unregulated. In endometriosis, unregulated. In cancer, you can have an elevated in CA-125, which is a marker of ovarian cancer. But guess what? That same inflammation is going to be elevated in endometriosis. In cancer, you have to diagnose it, usually requires surgery. Same thing here. And then the treatment of choice for all of these is surgery. So that's why it's similar. Now, is it the same pathology as cancer? No, it doesn't kill the organism. So the most common surgical presentations when we do surgery is we see adhesions, little scars. I think of it as like cellophane that wraps around the ovary, making it impossible for the egg to reach the tube, and that contributes to infertility. A lot of times the lesions are white, but sometimes they're not. So about 60% are scarred white lesions. Sometimes there's these little crazy pockets inside the smooth peritoneal wall, which should be completely smooth with no pockets. And that's, again, about 50%. Scarred black lesions that look like cigarette burns, about 50%. Clear vesicles, you don't see that as often, about 30%. And then these bulbous red lesions like blueberries, strawberries, or raspberries, I should say, only about 25% will look like that. What can be done about it first is surgical or medical oophorectomy, right? Get rid of the source of estrogen. But again, for infertility patients, this is not an option. And of course, abdominal or vaginal hysterectomy with removal of both tubes in the ovaries. Again, it's the most effective, but not for infertile patients. So how can we do it and help our infertile patients? Well, a medical oophorectomy just means we give you medicine that puts you into menopause. And you guys are taking that with IVF. It's called the Lupron, and well, we don't have Antagon anymore. We call it Ganirelix or Citratide. These are medical ways to make the body believe it doesn't have ovaries anymore. Then we have hormone therapy. Okay, hormone therapies, of course, birth control pills, progesterone only. And then you can do these agonists like Lupron, Citratide, Ganirelix, and now there's a new product called Orilissa, less side effects. Additional therapies, which are adjunctive, and we're going to be talking about that in the future, are things like non-steroidal anti-inflammatory drugs like ibuprofen, Aleve, Anaprox, acupuncture, of course, and then other modalities. So the question is, can you have endometriosis if older, if 50 years old and had it removed at age 46? Absolutely. How do we treat you? No two people are alike, even though these look like twins. Based on their signs and symptoms and based on their reproductive needs. And then based on an algorithm, a way of looking at the disease in terms of how to treat it. So stage 1 and 2, and you want to retain your reproductive function, then you do it by surgery. You treat it with laser, fulguration, or excision of the lesions, and that seems to do a very, very good job. And here you can see that with the use of laser, in the study of the 50 women who did the laser, of the 300 people with symptoms, 50 were infertile, and of those 50, 68% had endometriosis, and of those 68%, 51 got pregnant after surgery. So you can see that this does work. Is Lupron acetate used for endometriosis? Absolutely, XOXO, Sarah. And again, jump over to Facebook Live if you guys are watching it. For stage 3 and 4, as I said, you want to preserve your reproductive function, then really IVF is the treatment of choice prior to any surgery. And then finally, for stage 3 and 4, if you're done with your reproduction, then of course, extirpation of the uterus, a hysterectomy would be a treatment. Now, here are some of the drugs that people have used to medically treat endometriosis. Things that act like progesterone, like Depo-Provera, Megace. Things that have an androgen base to them, Danazol. Another androgen base, gestrinone. You see that in birth control pills. Then you have the things that shut off FSH and LH, which in turn shuts off ovarian function, like Lupron or Ganirelix or Citratide. So there are lots of these GnRH agonists and antagonists to help. Yes, pregnancy does help, and so birth control pills mimic a person being pregnant, and therefore you can get relief from that. Progesterones only, like hydroxyprogesterone acetate. Many patients, everybody seems to benefit about 50% no matter what therapy. RU46, which you now know as the abortion pill, that's been used for the treatment and it works. Danazol, it's a modified androgen. It decreases the estrogen in the ovary, exposes endometriosis to androgens, and endometriosis doesn't like that. But again, it's a teratogen, so you have to use birth control pills if you're taking Danazol. So again, you're going to see everything is 50% decrease in pain, 50% reduction in pain masses. The side effects are significant for things like Lupron, hot flashes, headaches, vaginal dryness, and you could have permanent bone loss. If you add back, so if you are on long-term Lupron, add back estrogen therapy, where you add a little bit back, and the best is norethindrone acetate, 5 milligrams a day. So that is a way to preserve the bones, but get the benefit of the pain relief. Non-steroidal anti-inflammatories, you start those early and you use them consistently and persistently. Gives the body a time to heal, gives the body time to adapt, and they're an ameliorative. They ameliorate. Medical management, up to 85% improve with the hormonal therapy for pain. For a pelvic mass, you can see actually a 50% decrease in size, but again, it'll come back. So what about infertility? Well, as I mentioned, that in stage 3 and 4, in stage 3 or 4, you're going to see this is a normal ovary. You can see this endometrioma is making a big part of the ovary non-functional. It destroys the normal tissue. It interferes with follicular development. It interferes with ovulation. It interferes with normal ovum pickup. And mechanically, the saran wrap is what I think of when I think of endometriosis. The endometriosis can scar, put up these adhesions around the ovary so the egg can't get out. Or it can cause blockages all along the fallopian tube. It can destroy the fimbria or fingers of the fallopian tube so it can't pick up an egg. Then the actual fluid inside, the peritoneal fluid, may interfere with the tube's ability to pick up the egg, and it may be embryo toxic or oocyte toxic or sperm toxic. And from animal studies, they see this increase in these defensive macrophages and prostaglandin responses that are contra to reproduction. The immune system, there's an increase in endometriosis in patients who have autoimmune disorders. So there's an immune component to the treatment. And one of the big things at CNY Fertility is that we treat the immune system. We have immune protocols 1, 2, 3, and 4. And please go and download our family building guide. It's on our CNY website. It's free, or you can buy it on Amazon. But it has a lot of information about the things that we do and why we do it. There are other things that can happen with endometriosis. It can alter prolactin. It can alter gonadotropin secretion. It can create a situation where you have luteinized unruptured follicle or Luff syndrome. And it can create a luteal phase defect. That's an old term, and miscarriages. So in some patients who've got done IVF and done genetically tested embryos and are not getting pregnant, we go in and guess what? We find lots of endometriosis. So for stage 1, why do we treat it? Because it shortens the time to conception and pregnancy helps. So 35% were pregnant with treatment, 47% were pregnant without treatment, and that's 70% of the controls were pregnant at 6 months, 50 are untreated at 12 months. So what it did is it got you there quicker. It got you there quicker. Stage 3, it's affected by removing the mechanical interferences. So here you see the outcome of surgical treatment in terms of ongoing pregnancies. So what it's saying here is that most pregnancies will occur within 6 months of surgery. So when you get the surgery, you should jump on getting pregnant as soon as possible. The way we determine the stages of endometriosis is by surgery. So in overview, the treatment of surgery for mild, moderate, and severe, the pregnancy rates for mild after treatment were 61%, 50% after moderate treatment, and then, moderate treatment of moderate disease, and then 40, again, so you see that the increase in length of time and severity of endometriosis does correlate with reduction in fertility. So anybody on Instagram, I'm still doing the talk on endometriosis, but we'll be getting some questions here shortly. Do you need to confirm the diagnosis? Some people say no, just try birth control pills and non-steroidal anti-inflammatories if you're not trying to get pregnant. If you feel better, leave it alone. If nodularity, though, is present, no amount of medicine is going to fix it. So from a pain standpoint, you need surgery. And if you've put patients on high doses of non-steroidal anti-inflammatories or GnRH and you still have added antidepressants, then actually surgery is indicated. And if you have cyclic pain with endometriosis, you really, really need to go to surgery. So the diagnosis of endometriosis is surgical. There's no appearance which is never endometriosis, and there's no appearance which is always endometriosis. So it's a little bit difficult to diagnose. Anywhere from 14 to 60% of endometriosis was documented by the pathologist. So the gynecologist was in there doing his job, got some tissue, sent to pathology, and they wrote back, hey, this patient, so it surprises the gynecology. And according to Dan Martin, all women have endometriosis at some time in their lives. Simply means that the explants from the uterus spread, and that spread caused you to have endometriosis. The long-term management includes anticipation. In other words, endometriosis can be persistent and can recur. So you gotta anticipate it's going to be that way. Surgical management, if child-rearing is complete or is not an issue. Medical management in conjunction with surgical with close long-term follow-up. Infertility from endometriosis is helped by medical and surgical management, and usually they need a multidisciplinary team to do the whole process. Anyway, that was a quick review because I had already gone through some of this last week or 2 weeks ago. I'm going to be doing 2 more lectures in this series. It's going to be in 2 weeks from now and then 4 weeks from now. But anyway, the main reason I'm harping on this is I think it's underdiagnosed. I think this unexplained infertility can be explained if you had done a diagnostic laparoscopy. So anyway, so there you have it. Let me take a quick swig here, and then I'll be ready to answer your questions. So everybody can jump back on either Instagram, Facebook, wherever you want to be, and I'll start answering some questions. Does donor egg increase pregnancy rates for women with stage 4 endometriosis? Absolutely, because that egg is not influenced by the metabolic side of endometriosis, the pathologic metabolic side. If you're doing genetic testing because of your age and also sex, does embryos have to be frozen first? Yes. Yes, we have many folks in our office that speak Spanish, and if the doctor doesn't speak Spanish, what you'll have is a concurrent call with both the doctor and one of his MAs who speaks Spanish. During my HSG, they found 3 masses in my uterus. I have a hysteroscopy on the 21st. Could this be causing me not getting pregnant? Absolutely. And what could the masses be, Catherine? Probably a polyp, most likely a polyp. My AMH is 11 or 10 and a half. Is that a good sign? That's not good or bad. Is there any way that laparoscopy can clean up and attempt pregnancy? Of course, laparoscopy can be used to get rid of adhesions. What if you have blocked tubes? Would that be endometriosis? Sure. That could have been caused by endometriosis. So that can be caused by sexually transmitted diseases. When do you recommend to postpone a fresh transfer and a frozen embryo transfer? When you have hyperstimulation, or you have so many eggs that that your estrogen is high even without hyperstimulation, or you have premature progesterone rise. Could polyps turn to cancer? Yes, it can. It's not turning to cancer. It's just you're catching it early when it's not cancer. Can endometriosis cause an ectopic pregnancy? Yes. Just simply by mass effect or by distortion? Absolutely. How can endometriosis be diagnosed? Surgically, with surgery, diagnostic laparoscopy. Does Lupron Depot help if laparoscopy surgery was more than a year ago? Absolutely. Can low AMH have any chance of having a baby? J-Bell, yes. As long as we can get an egg, the AMH is just an indicator. Thank you. I love answering questions. I had laparotomy in January of 2020. We did IVF in May of 2020 with no success. We just did our second retrieval and transfer in July. That was unsuccessful. The ultrasound is showing a small endometrioma. Should I have another surgery? Yes. Don't wait for your next transfer to fail, Polly. Get it before your next transfer. Will endometriosis affect implantation, cause recurring implantation failure? Yes. So make sure you get it managed. You're welcome. Rachel, are there any CNY close to Philadelphia? We're actually, I'm not sure when, but we are opening an office in Philadelphia. How's that for being close, Rachel? Lisa, what estrogen and progesterone levels do you like to see at the Midway Labs post-transfer? Progesterone over 10, 20 is nice. Estrogen, I don't worry about. Does endometriosis affect egg quality? Yes. Should adenomyoma be removed before IVF? Yes, if it's distorting the category. What is the difference between laparoscopy and hysteroscopy? Laparoscopy, think of the lap, your belly. So that goes through the belly. Hysteroscopy, think of hysterectomy, removing the uterus. So hysteroscopy goes in, through, and up the uterus. So hysteroscopy is in the uterus. Laparoscopy is through the belly button. What can I stay tuned to find out when we open in Philadelphia? I don't know the answer to that, but stay tuned, okay? Or ask Dr. Kills on one of his lives. What if you have blocked tubes? Can that be endometriosis? Can blocked tubes be undone? Blocked tubes can be endometriosis, and sometimes it can be temporarily fixed, but not very effectively. Get it open soon, Rachel. No, just come to Atlanta or go to New York, or you can now get some monitoring done, I think, next week down in Sarasota, Florida. Come out to Colorado. Believe me, you can travel. Facebook, Vanessa, thank you. Rodriguez, there's a CNY Fertility Facebook group. Click that link below. You guys know how to do that. What is the time window for letting me know I need to travel for retrieval? I'm in Tampa doing monitoring there. So typically, you want to be on the road to wherever you're going on cycle day 9, certainly no later than cycle day 10 of your treatment. They are only doing monitoring in Atlanta. Yes, that's absolutely right. We have a lot of monitoring places, and then we have, it costs $1 million or $2 million to build IVF labs. So if we start building IVF labs everywhere, then of course the cost of IVF goes skyrocketing, and we don't want that. So yes, there's a little bit of travel in there. Can a submucosal leiomyoma cause infertility? Absolutely, Melanie. Absolutely, because it's pushing in to the mucus side of the endometrium and distorts the cavity. Not only can it cause infertility, but it can also cause miscarriages. When I had my 2 ectopics, with the first one I almost bled out in my abdominal cavity, I was in shock. With the second, it was more. My heart tried to stop. With bleeding into the abdominal cavity, raised the risk of No, not at all. It's not bleeding in the cavity that makes the matter. It's endometrial tissue, menstrual blood. It's the endometrial tissue in the blood, not just blood. If I'm doing a laparoscopy, should I just go ahead and get my tubes removed at the same time, Amanda? You should. If you have damaged tubes, yes. Otherwise, no. Do any other locations do laparoscopy? Yes. All of them, I guess. What should I say? All. I think in Buffalo and Albany and in Colorado Springs. Yes. What are the reasons for only 2 follicles responding well to stims? Well, it depends on your age, mostly, Samantha, and your AMH. My first letrozole medicated cycle failed with CNY on my second, and I'm so grateful for CNY. They are my saving grace. Well, we are very happy for you, Isa Perola. I have an issue with fluid in my uterus every cycle. So how do you manage excess fluid? Well, try a natural cycle. Sometimes that really can help for transfers. Anna, if not having pain but had 2 failed PGT embryos transfers after having endometriosis, exercise for you, should I have another lap done? Yes. Yes, Anna. Yes, go get another lap done. Samantha, I'm at 26 and was told AMH was normal. I'm not sure why you only have 2 follicles growing. I did a modified NAT. Well, that's the reason. Or I think, right? No, it's a different person. Okay. I had my endometriosis treated last year in August. Would it come back this soon? Yes. So within the first 6 months is the magic window. My first letrozole medicated cycle failed, and on my second, okay, we already said that. Would being on metformin help with recurrent early pregnancy loss for a patient with PCOS? Not sure I know the data on that. Would an HSG tell anything pertaining to endometriosis? Not likely. Amanda, my lining doesn't thicken. That's a real problem, I'll be honest with you. It's difficult to try to figure out how to manage that. Yeah, it's very difficult. We could do a whole talk on that. I've had endometrioma, was told I don't have endometriosis. Is that possible? No. Endometrioma is endometriosis in the ovary. That's exactly what it is. However, what they might have meant is that you don't have those other implants that, does Orilissa reverse endo, or does it just help with the symptoms? It helps with the symptoms, and I believe it also shrinks the endometriosis while you're on the drug. Would you recommend doing a laparoscopy to treat it again? Yes. I had an ERA and 3 transfers, 2 of which were PGS normal. I lost that. Does anxiety affect success rates? Yes. But not in the way you think. Probably affects the central nervous system. What is the window to get pregnant after Lupron depot treatment within the next 3 months? How likely will IVF work with stage 4 endo and have had 2 excision surgeries for them? Your likelihood of success, Nicole Peters, is your AMH and your age. How long do you experience cramping during a 3-day transfer? Never. You should not experience cramping. So keep yourself well hydrated. Make sure you're doing your progesterone. Make sure you're doing rest. But being well hydrated is probably the most important thing. You're welcome. How long after a laparoscopy and tubal removal can someone transfer? 4 to 6 weeks. Does having the uterine anomaly corrected and endo removed solve the problem, or does endo usually return? Endo Endometriosis always returns. Always return. Always returns. What are the percents if we went ahead with retrieval for date for only 2 follicles that they would make it to PGT testing of all? Probably 10%, Samantha, if you had only 2 follicles. I had a fresh transfer, did an ERA, and then had 2 frozen transfer, but they are failed to implant, even though lining and hormones look great. 2 frozens with normal. So do diagnostic laparoscopy, Christy Polasek, and you may have endometriosis. Does the Colorado office do laparoscopy? Yes, we don't do it in the office, we do it in the surgery center. All righty. How long after laparoscopy can you start time to TTC? Time to conception? What is TTC? I don't know. If you mean to get pregnant, then I would say 4 to 6 weeks. All right, I stumped you guys. Any other questions? It's a lot on endometriosis, trying to conceive. Thank you, thank you. All these acronyms. So we made the right decision to trigger and wait till 3 starts stimming next month and with new protocol. Great, Samantha. Great. So skip a cycle, then next cycle after surgery. Perfect. All righty, what happened here? Nobody's doing any talking on Instagram? Any questions on Instagram there? Nope, I'm not going to be on a video. I did IVF, had 7 follicles, but they did not get any eggs. They're not sure what happened. Unfortunately, I'm not sure either. What is the magical window after polypectomy to try to conceive? It's 4 to 6 weeks. Endometriosis always comes back, even if older. Pretty much yes. Pretty much yes. But again, it may not affect you, but pretty much yes. Any recommendation on what patient could do before the consult, such as blood work? Yes, go to CNY Fertility, download the Family Building Guide. There's a whole complete list of things your doctor can do before you're even referred. How does letrozole help with PCOS patients? It helps you ovulate. Any way to improve sperm motility after vasectomy reversal? Yes, you could try Clomid. Your urologist can. What symptoms would you have if you had endometriosis? Oh my gosh, Samantha, I just went through a whole lecture, a whole lecture on all the symptoms and signs. Just rewind the lecture. But that's so funny. That was the whole lecture, my dear. Let me see if I can pull that up for you. That's so funny. All righty, let me show you this. Let me come back here to this side. Let me do this. Let me do that. So again, pain is the first clue. Cyclicity is, so if it's cyclic pain is the second clue. If it's chronic, it's the third clue. Okay, those are the clues. Then dysmenorrhea, painful menstruation, dyspareunia, painful intercourse, premenstrual spotting, chronic pelvic pain, bowel or bladder problems, mass effect on the uterus. So lots and lots and lots of things can are signs and symptoms. Is it recommended to have a frozen transfer with endometriosis? Not really. Okay. Any way to, by the way, all of these lectures are recorded, but they're all recorded. So you can always just go to the CNY Facebook page and find them, or on the website. Are you willing to work with a 44 or 45-year-old who are trying to use? Absolutely. Do we work with people who have elevated weights? Absolutely. Absolutely. My OB did an HSG and said I either had a submucosal fibromyalgia or just a gas bubble. Well, you better find out which it is, because one requires surgery. How long do you experience cramping during a 3-day? You do not experience, Stella, cramping at all. So do you see more success with fresh transfers for those with endometriosis? It doesn't, there's no difference. There's no difference. Is it recommended to have a frozen transfer with endometriosis? No, that's not a recommendation. Do the majority of non-tested abnormal embryos just fail to implant? Yes. Or should you be more concerned about miscarriage? I'm 40. Well, the reason they don't, yes. I mean, the answer is yes and yes. I mean, those are the two big things: is failure to get pregnant and miscarriages as we get older, above 35. How long does a trigger shot stay in your system? I have no idea what you mean by that. It only has to work at the moment that it works. It doesn't have to stay in the system for days, if that's what you're asking. Would you do ERP before laparoscopy or lap then ERP? ERP. Oh, the ERP. Well, it doesn't matter the timing on that, Caitlin. Can I have an IVF even if I haven't done a lap? Yes. Yes, it is recommended you do the laparoscopy if you have a problem, pain, all the things that I discussed, or you've tried IVF and it's not working. Miss Cuckoo Kisses. What about a 50-year-old that has had a partial, can egg retrieval be possible and are eggs still good? Not likely, Miss Cocoa Kisses. Not likely. I would say pretty near 100% of those women will likely use donor eggs. Is there any difference with someone who has a pituitary tumor being managed, but I have several PCO patients from, I have severe PCO from acromegaly and suspected endo. What would be successful for me, fresh or frozen? Doesn't matter. So far, I've had 2 failed transfers. Should I do an ERA on lap first or lap first? Well, it doesn't matter what order you do it, and you may even be able to get your lap and while you're sleeping, get your ERA done. For someone who just had a tubal ligation, what testing is required? Go to Tiara, go to our family building guide at the cnyfertility.com and the resource page, download it. It tells you all that, what you need. What is considered a good number of eggs retrieved for a 31-year-old with low ovarian reserve? Well, 31-year-old, 15, probably 7 or 8. I don't know the cost for stuff, so Samantha Teehee, how expensive is embryo adoption? Yeah, I actually don't know those numbers. You can call our financial team or go on our website. Does laparoscopy negatively affect AMH? I have had one laparoscopy already. It can, but if you need the laparoscopy, do the laparoscopy. Can endometriosis cause implantation failure? Yes. Could uterine polyp turn to cancer? I've already answered that. Yes. I have PCOS and I had an HSC done, but there was no blockage and fluid free spilled into the uterus, but still not pregnant. Well, you need treatment. That's Isa Perla. Oh, Alyssa, Danielle, thank you so much. I thank you. You guys are wonderful. I mean, it just, we're kind of running out of time here, but I just want to tell you, one of the most grateful things I have is my participation in the CNY family and all of its amazing staff, amazing nurses, medical assistants, lab assistants, embryologists, administrative people, the CRNAs, the anesthesiologists, the surgeons, the doctors, the nurse practitioners, the financial folks, the call center, the global travel folks. These are just fabulous, fabulous people who are working their hearts out to help you all. So anytime you can, give them a compliment. We get yelled at a lot because we're not perfect, but if you see us doing something nice, please tell us. Thank you. What protocol is recommended for transfer for someone who has diffuse adenomyosis? Michelle, there's no protocol for adenomyosis or adenomyoma. The protocols are associated with getting eggs. So anything we can do to optimize getting eggs, that's the protocol for you. Cassie, sorry if this was answered, just got on. 4.02 good for AMH, yes, is good. Would you suggest genetic testing or not? Yes, I would suggest it. The best patients to do PGTA on are those between 35 and 40. That's it. What supplements help low morphology? Zinc, Serovital, CoQ10, vitamin E, vitamin A, antioxidants, So ubiquinol, a good men's multivitamin. Are there any supplements? Yes, we're going to be talking about the dietary management of endometriosis. Stay tuned. I actually think that's next week or 2 weeks. No, 2 weeks from now. We'll be talking about that. It's just too long a discussion now. You're welcome, Cassie. How do you book a consultation? You just simply go online to our 800 number and say, I would want to book a consultation. It's that easy. How long does it take to get a meeting in Colorado? We do everything actually by telehealth. So you don't have to come to Colorado. You can do it just through telehealth. There you go. Jess Nosler, thank you. 60 days from the day you call us is what they're saying. And then please get on our cancellation list. Everybody. Hey, Ann Tribble. Good to see you. Oh, I'm so sorry, Ann. I'm so sorry. It didn't stick. I'm sorry. I think the Victoria, if you don't have, the financial side of how much things cost, I actually don't know. What vitamins do you recommend to take while trying to get pregnant? Just download our family building guide, Alicia RMZ0220, and it has them all listed there. I've been feeling down for a long time for the long wait, but got a call today and the appointment was moved up 1 entire month. Yes, that's my point. Tell them you want to be on the cancellation list. We pack our schedules. If somebody doesn't answer the phone 3 times, we move on to the next person. Please make sure you have voicemail. Please, if you don't, just have voicemail. Do not have those things where the voicemail was not set up, no voicemail, voicemail is full. Guys, that you can't do that in infertility care. You can't. You have to be accessible. And I'm sorry, but you got to be. Hello, Lindsay. I know it's weird. I'm actually starting at 4 o'clock, as most people know. We're going from 4 to 5 now, rather than 4:30 to 5:30. So I apologize for people who are just jumping on, but this is all recorded. Can you get acupuncture the day after a laparotomy? Yes, Alyssa, you absolutely can, as long as you feel well. Is there anything I can do to increase my chances of implantation with endometriosis? Yes. First, make sure your endometriosis niece is treated. Secondly, acupuncture. I didn't talk a lot about acupuncture, but for pain, for endometriosis, absolutely. They have herbs, they have treatments, absolutely. Okay, after embryo transfer, do you do lipids? Do you do lipids? I think you mean intralipids. In my mind, it's likely doesn't matter, but you might want to ask take a look it up on our website. What is the difference between an embryo on day 5 and 7 embryo on day 6? I don't know. Okay, Dariana, here, thank you. Dariana, the difference is in 1 day 5 and 7, and I don't know embryo on day 6. I don't know what a 7N embryo on day 6 is. Okay, so yes, day 6 embryos, day 7 embryos are basically embryos that can implant. That's why we grow them. So stop with the grading. Just don't worry about the grades because they're yours. Who cares what the grade is? It's your embryo. It's beautiful. By definition, it's beautiful. So use your embryos. Do not get lost in grading. I can tell you grade A or the best embryos don't stick, and the worst embryos graded do stick. So therefore, grading makes no sense. So don't get too much caught up in that. All righty. Thank you, Bird Bash. Yes, send me some kisses. I'm running out of energy. Thank you. I love the kisses on Instagram. All right, so next week, 4 o'clock Mountain Time, questions and answers. Oh, thanks for the question and answers next week, Q&A. Week after that, it's part 2 of the 3-part story of endometriosis, much more detail about the testing and the treatment. And then the last part is talking about endometriosis and infertility, but a lot of data. Thank you for all those lovely kisses, everybody. I really appreciate it. What's a good number to call for appointments? Our 800 number is the best number because it's the only number to call. So day 5 or day 6, there's nothing you have to worry about. If you have a day 5 or day 6 blastocyst, God bless you. That's a good embryo, good life, good baby makers. So Dariana, 1988, absolutely No worries about that. I have 2-cell and a 5-cell. Should I have them incubate up to or just transfer as is from frozen? Lindsay, that's a great question. Oh, great question. Not 100% sure. Well, here's the thing. You can put them in the uterus and let the uterus incubate them, or you can incubate them in the laboratory. Most folks like to incubate them in the uterus since they're already there. Which is better? That's a controversy. Are they doing embryo transfers in Atlanta? No, no, no. All righty. Well, everybody, thank you for this another evening, another wonderful evening. I hope you have all pregnant thoughts. Please read our family building guide. Please use the portal. Don't try to use the phone. It'll drive you crazy because there's 1 or 2 hour wait on phone calls, but the portal is managed very effectively. Please take the supplements. Please do acupuncture. If you're not near an acupuncturist, then go to the American Board of Oriental Reproductive Medicine, ABORM.org. If you're near the healing arts centers, jump over to those guys. They're great. But just keep hopeful, because I think that's the key. Keep hopeful. So anyway, everybody, we'll see you in a week. Have a wonderful day, and thanks for sharing. Thanks for sharing. Bye, everybody.